Greeting everyone. My name is Sahar Mohammed Hisham, and I am board certified infectious disease clinical pharmacist, UAE licensed pharmacist, and hold my master degree in the clinical pharmacy. It's my pleasure to welcome you today to the third lecture in our series in the broad intervention in the antimicrobial stewardship implementation. In our lecture, we focused on the pre-authorization strategy, discussing how to start and what are the challenges, obstacles commonly arise when you are going to implement the pre-authorization and how you can properly design and implement the restricted antimicrobial list. The second lecture, we moving forward to the beyond restriction and discuss the most commonly used broad intervention in the stewardship practice, which is prospective audit and feedback. This is a powerful tool and not only guides the antimicrobial use in the real time, but also build a collaboration and education among the prescriber. Today, we were talking about the third most common used tool in the antimicrobial stewardship implementation as one of the most common broad intervention, which is antibiotic timeout, ensuring the appropriate therapy at 48 hours. Um, this is a very powerful tool, and again, I will discuss the difference between the timeout and the prospective audit and feedback. Just for to make a refresh, these are the core elements for the CDC. These are the broad interventions, which are three broad intervention. Is there is a formal procedure for all the clinician to review the appropriateness for all antibiotics 48 hours after the initial order, which is antibiotic timeout. And as you see, the CDC confirmed that the antibiotic timeout is the main duty or the main focus for the clinician, not the ESPT. Okay, so this will let us see what is the antibiotic timeout. What is the antibiotic timeout? It is a structured, deliberate pause at 48 hours after starting the empiric antibiotic. So you should make a structured, or you should have a structured approach after 48 hours from the starting of the empiric antimicrobials, reassess the therapy with the updated clinical and micro data. And that's why you can provide the timeout after 48 hours. So you have the adequate time to see the patient's his response to the antimicrobials and also the culture results. It's recommended by the CDC as one of the most important broad interventions. What are the objectives for the timeout? The objectives for the timeouts are main four objectives. First is to verify the indication and to see if the antibiotic is still needed or not, and it's appropriate to document the indication or to verify whether or not the antibiotic is still recommended. Also to optimize the spectrum, can the therapy be narrowed or stopped? Also to adjust the dose and route and see if the patient is stable and he's candidate to make IV or to be switched from the IV route to the oral route. And also is the dose is correct regarding his renal and hepatic function. And lastly, to set the duration and the stop orders. Okay. So it's very important to set the duration and the stop dates because this will help you to decrease the unnecessary prolonged courses. What are the key elements to review at the 48 hours? It's very important to put a structure or to put headlines which data you will be focused on in order to make a structured approach for the timeout. First, you must focus on the vital signs and the clinical response, the fever trends, and the white blood cells count and the organ function. Also, you must focus on the culture sensitivity results, imaging finding, or the new diagnostics and the patient comorbidities and risk factors. What is the implementation steps? How can you provide the timeout? You can provide the timeout based on the automatic 48 hours alert. Maybe the pharmacy provide an alert after 48 hours from the starting of the empiric therapy, or your EMR provide you with the automatic alert or with the alert whether or not with the list of the antibiotics that is need to be monitored. Also, will assign the responsibility for the clinician, and this is one of the core difference between the antibiotic timeout and the prospective audit and feedback. As you know, the prospective audit and feedback, it's also a review, usually after 48 to 72 hours from the starting of the empirical therapy, but the persons who are responsible for the prospective audit and feedback usually are the pharmacy or the ASP team or the ID physician, but the timeout is usually the main responsibility for the clinician. Also use a standardized checklist for each review, and you should document your decision. It's very important to document your final decision, whether the patient will be kept on these antibiotics, you will escalate, de-escalate, or you change the route, and also the estimated durations for these antimicrobials. It's very important for any intervention to be followed by KPIs, or by measuring the KPIs uh, to uh, to see if this intervention is really helpful or not. So from the KPIs or from the measuring of the impact that we usually use it when we are measuring the impact for the timeout. We usually measure the percentage for the antibiotics that are de-escalated or discontinued after the timeout. Okay, and as you see, we are not measuring the antibiotic de-escalated or discontinued alone. We usually focused on those who are de-escalated or discontinued based on the timeout or based on the clinician response. Also, you can measure the DOT or the DDD reduction for the spectrum, broad spectrum agents, and also you can measure how you are adhere to the guidelines and how much you save the costs from the use of the broad spectrum agent. Also, you can measure the resistant trends and the decrease in the C. difficile rates. There are common barriers that face the clinician when they are going to implement the timeout. And I also try to put some solutions, practical solution that can decrease those barriers. The first barrier is the time. Usually the busy clinics, it's very difficult for the doctor to make, during the short appointment, to make a follow-up and to see the appropriateness for the antimicrobial. So you should integrate this timeout checks and the timeout as an intervention in your routine follow-up. So it's part from the follow-up is to make a timeout if the patient is on the antibiotics. Also, there is a limited access to the updated culture and results. So it is very important to make a good communication between the lab and between the primary care physician, and should be a continuous follow-up and continuous sending for the updated data regarding the cultures for every patient. Okay, this will help the doctor to, or the clinician, to be updated with the recent data. Uncertainty about the local guidelines. Sometimes the clinician are not fully aware about the local guidelines and about the recommendations of the local guidelines. So it's appropriate for the ASP team, especially the pharmacist, to offer a brief refresher sessions for those local guidelines and to provide the most updated recommendation based on the antibiogram or based on the recent recommendations and based on the availability of those antimicrobials inside the pharmacy. Also, there is a very important barrier, which is perceived patient expectation. Sometimes the patients themselves are they will not be satisfied to not to take antibiotics. They usually insist to take antibiotics. So it's very important to educate the patient proactively that we will review after 48 hours your condition. May be good without using antimicrobials. There will be others effective treatment options other than antimicrobials. So it's very important to educate your patients, okay, and to make them aware that they will not start antimicrobials. Lack of the feedback and reinforcement. Sometimes the outcomes are not shared successfully So sharing successful stories and sharing reduction in the resistance or adverse drug reaction in the clinic meetings or in the huddle, it's very important in order to motivate the other clinicians to do time out and to know that this intervention will not compromise the patient outcome. This is my take home message. 48 hours antibiotic time out is a simple, powerful intervention, but it needs a lot of effort and need a collaboration between the clinician and the other healthcare provider in order to implement it. Pause, reassess, and optimize. It's very important to take a pause after 48 hours and reassess the use for antimicrobials. It will protect patients, it protect the community by the reducing the resistance and also saves resources. Please get in touch for our service. We provide a professional courses in the infectious disease, totally English or hybrid Arabic in English. We also provide an online consultation for antimicrobial stewardship implementation, how to effectively implement your antimicrobial stewardship program. Also, you can contact us on the WhatsApp for more details about the courses or about consultation. Thank you for your attention and your attendance. I hope it could be a helpful lecture, and I will share with you the link for the whole playlist, okay, for all the three broad intervention. Thank you and goodbye. See you in the next lecture, inshallah.